Hi everyone. Today we're going to move on and talk about a category of disorders that are unique to childhood. And this category in the DSM has just grown tremendously because many years ago, severe problems in kids were just limited to schizophrenia childhood type. So every problem that kid had was just chalked up to schizophrenia. Now we've got a number of categories of developmental disorders. We have, and the main one we'll talk about are neurodevelopmental disorders. We have communication disorders like mutism. We have tic disorders, TIC, which involves repetitive behaviors. We have conduct disorders. We have feeding disorders. You don't need to write all those down. I just wanted to give you an example of the different kinds of disorders. And children often tend to be especially vulnerable to certain kinds of disorders because much physical, cognitive, and social development obviously occurs in childhood, and we need to know what skills are disrupted in order to form a treatment. So the estimate is about 1 out of 8 kids experience a diagnosable psychological disorder. They might not actually be diagnosed, but they have enough symptoms that they meet the criteria. Today, what we're going to talk about are neurodevelopmental disorders. Oppositional, defiant, and conduct disorders are really interesting. I'm not going to cover them here, so be sure to take a look at those in your textbook. Okay, so with neurodevelopmental disorders, this category contains the 2 most commonly diagnosed disorders in kids and the ones you're probably the most familiar with, which is ADHD and autism spectrum. So the way to think about any disorder that falls under this category is that they are disorders of brain functioning that really most of them are present at birth, if not shortly afterwards, but it involves brain functioning issues that lead to a number of problems, cognitive, social, emotional deficits, which really covers the major ranges of development that kids go through. These are not minor issues in development, not minor problems. We're not talking about things like shyness here. These are major issues that cause that maladaptiveness that we talked about at the beginning of the semester. It's going to interfere in kids' functioning in some way. So the first one we're going to get right to it to start with is autism spectrum disorder. Everyone's heard of this. It actually has been around for a while. It was identified in 1943, but as we're going to see, because of pretty much an explosion of better diagnosis tools, the numbers have really gone up and up. And I think I mentioned this when we talked about the DSM, but there's a lot of controversy about this. In the most recent version of the DSM that came out in 2013, autism and Asperger's syndrome were combined into autism spectrum disorder. And there was a lot of backlash, particularly from people affiliated with the Asperger's community, because they pointed out, and rightly so, that a person diagnosed with Asperger's is very, very different and displays very, very different characteristics than a person who has severe autism, and that is true. But the reason they decided to collapse it all into one category is because of the research and the science. So the research finds that the same kinds of disturbances are affected in both autism and Asperger's. The same neurobiochemical processes are affected, just to a much different degree. So the opposition of the Asperger's community is justified and well known, but based on the research, this is what the American Psychiatric Society decided to do. So autism spectrum disorder involves a wide range of problematic behaviors, significant impairment in social interactions, communication with others, behavior patterns, and activities. So all 3 things are affected. The reason that this is called a spectrum is not because of what's pictured at the top. So when we talk about the autism spectrum, this is what people imagine, that at one end are the people who may meet more Asperger's criteria, have less severe disorder, and at the other end are the people that have a lot more symptoms, and a lot of these people need to be really intensely cared for. But the reality is the spectrum looks much more like this. So we take all the different abilities that are impaired through autism, sensory, language, motor skills, perception. Executive function is the problem solving and the planning mechanisms. Those are all on a spectrum. So for example, a person who we would normally say falls on the less autistic side of this may have very low impairment in 4 of these, but high impairment in 1 of them. So now when patients are treated, when we try and figure out what's going on, they look at all these different components separately to figure out where they are on the spectrum. So this is no longer a correct model to understand this. This graph shows a good example of the estimated autism prevalence just a couple of years ago. And remember, these are always estimates because there are probably a fair number of people who are yet under or undiagnosed. The most current statistic I found, and this was just released back in January of this year, shows that 1 in 54 kids meets the criteria for autism spectrum disorder. And that seems to be largely because of just heightened awareness, increased diagnosis, and really understanding of it. But if you look at this chart in the United States, it's amazing. Just back, 15 years ago in 2004, it was 1 in 166, and then just has been dropping every couple of years. And the most recent that I've got here from the CDC is 1 in 59, and now they've got it at 1 in 54. The thinking also used to be that there were some real racial, ethnic disparities in diagnoses, but now we know as the diagnostic systems have improved, that disparity has been erased. Most of the children diagnosed with this are males. About 80% of the diagnoses are made in males. We're still trying to understand why females seem to be less susceptible to this, less often diagnosed. As I mentioned, all races, all socioeconomic statuses, and usually this is identified by about age 2.5, but many times it's suspected in infancy. And as I'm going to talk about, the earlier the diagnosis, the better the outcome. The earlier interventions and treatment can begin, the much better the outcome for kids. This is oftentimes why pediatricians will do screenings at yearly checkups for some of the symptoms here, but most of the time it's identified during toddlerhood. I'm going to put the link to this video down in the discussion section, or the comments, or whatever it's called, description section. And I'd like you to take a look at it. It's just about 5 or 6 minutes, but it's a really interesting recap of the history of the ASD diagnosis. So be sure to go and take a look at that. Now, as far as the symptoms or the characteristics of these disorders, there's a lot of them. And if you've read the text section, you'll see that. So what I decided to do, and you don't have to memorize this by any means, is I just put this chart up here just to show you a little bit of the different dynamics and dimensions that are used. So I just want to give you a couple of examples of each of these categories. So impaired social interactions are oftentimes the main characteristic of ASD. So let me give you some examples. Many times kids with ASD are described as good babies initially because they're not demanding, they don't seem to need a lot of attention, they don't often cry. Those are generalities, remember, there's lots of exceptions. But people also describe them as they're not necessarily cuddly. They don't often smile or make eye contact, and that lack of eye contact is one of the first cues for folks. They don't seem to really notice or pay much attention to other people, and many times they don't respond to the name, which typically developing kids would do that. They may not show facial expressions, so they may not smile or express many different emotions. And then as kids start to get older, typically developing kids start to really enjoy the presence of other children pretty early on, even as young as 6 months. But kids with ASD don't necessarily make friends. They may not enjoy or have the ability to develop relationships like other kids do. There is impairment in communication. Let me give you a couple of examples here. About 40 to 50% of kids diagnosed with ASD never really acquire useful speech. They may be able to parrot phrases they hear or mimic phrases they hear, or they may be able to respond with grunts or incomplete kind of phrases. And they don't learn speech well by imitation, which is how typically developing kids learn that. Some may not speak at all. Others may only answer yes or no, or just repeat things that they've heard other people say. Now, many kids who are on the spectrum will comprehend speech, yet they can't use it themselves. So when you say something to them, they'll understand, but can't necessarily respond. Other kids may have abnormalities in the loudness of their speech. They may speak unusually loud. The rhythm, they may use reverse pronouns, so they may refer to him or herself or themselves as you. They may not they may not use their own name, or they may refer to themselves in the third person. So those kinds of things can happen. Restricted behavior and activities and interests, a couple of examples. Many kids with ASD are bound by ritual, both in their own behavior and in demands they impose on others, bound by ritual. So some kids will engage in repetitive spinning or rocking, waving their hands. Some kids engage in headbanging, which of course is a harmful behavior that needs quick intervention. Um, they really need sameness in lots of situations. So one example I read about, and I personally don't see children in my clinical practice, so I haven't had experience with this one-on-one, but one experience I heard about, a teacher said to a child, "Good morning, I'm very, very glad to see you." And that's what she says every morning to the child. And one morning she said, "Good morning, I'm very glad to see you." And the kid just could not handle it. So that things have to be the same for many kids, not all, and that repetition is important. They may form strong attachments to unusual objects, not necessarily a cuddly blanket or a teddy bear that some kids would, but things like rocks or light switches or keys, unusual kinds of things that are not particularly toys and things that other kids don't. And then many times when their preoccupation with that object or routine is disturbed, they may have really problems dealing with that emotionally. So one researcher said that some kids with ASD are obsessed with the maintenance of sameness. That's one way to think about it. There is also a wide range of IQ scores that go along with autism spectrum disorder. 75% of those diagnosed have some level of cognitive disability and will need special education or some kind of special services. And this ends up being somewhat prognostic, as I'll talk about here in the next slide. It has to do with prognosis. So the best outcome in terms of prognosis for kids with this disorder is the ability to speak by age 5 to 6. That's a really good sign. An IQ of over 70. So if we think about IQ, generally between 75 and 115 is within the average range. So this is just slightly below average. And then later onset of symptoms are predictive of a good prognosis. So there are some cases of autism spectrum disorder where kids seem to have a relatively typical babyhood and infancy, and then the symptoms just kind of come on sort of acutely, and researchers are having a hard time trying to understand that. Okay, how about the causes of this disorder? Get into etiology a little bit. So we know that there are some genetic links. Prevalence among siblings is 1 out of 10. So if parents have one child who has been diagnosed on the spectrum, they have a bit of a higher likelihood to have another child, but it's not huge. With MZ twins, with identical twins, there's a 60% concordance rate. So as we talked about, that means if one identical twin is on the spectrum, there's about a 60% likelihood that the other one also will be. And then we know for people diagnosed with autism, they are more likely to have relatives with other cognitive or social deficits. So what that shows us is that there really is a spectrum of these kinds of disorders, and some people, they may not even be within the diagnosable range. So just something to think about. Other things in terms of causes, they have found a link between prenatal and birth complications of all ranges, and that's something that they're still really investigating. But when they talk to parents of kids on the spectrum, they find that there may have been some complications at birth. Okay, now this is called a neuropsychological disorder, neurodevelopmental disorder, because obviously there are neurological deficits. I am not expecting you to understand all of this. I just want to mention a couple of things that they have found. Kids who are diagnosed on the spectrum tend to have underdevelopment in the cerebellum, which of course is the brain structure on the very back of the brain that's largely in charge of balance and motor movements. So we know that many kids with autism spectrum disorder have difficulties and struggle with these developmental skills. There seems to be some frontal lobe dysfunction. Frontal lobe activity tends to be decreased in kids with autism spectrum disorder, and that, of course, that frontal lobe is in charge of higher order thinking, planning, executive functioning. And then we also know that there are some abnormalities in the limbic system, in particular the amygdala, which is in charge of our survival instincts and our emotional responses, including aggressive behavior. And we know aggression is oftentimes one of the main issues with kids with autism spectrum disorder. And then, as I just mentioned, frontal lobe and temporal lobe. Temporal lobe is in charge of speech. That's right in this area here. Activity tends to be decreased. Now, how about psychological causes? Let me first start off with what the researchers found don't seem to be the case. First of all, it's not poor parenting, and there's still some anecdotal things going around out there talking about how, it's the parents and how they were raised. It is not vaccines. There was really a lot of anecdotal evidence a number of years ago showing that in particular the MMR, the measles, mumps, and rubella vaccine that kids got when they were relatively small, they have to get a couple doses of it throughout childhood, led to autism spectrum disorder. And there's a lot of people in the anti-vaccine community that still swear by it, because there was one paper published many years ago that speculated the link. And so people have just blown that out of proportion. Now, I want to mention that study has been retracted. They found that the author falsified data. And so since then, this has been heavily investigated. It's a huge problem when parents choose not to get their kids vaccinated because it reduces the herd immunity to many diseases like measles, all those, rubella, polio, that we've pretty much wiped out because of vaccines. So vaccines are not implicated at all. There is zero research evidence that they have anything to do with autism. What we do know is the case is that kids with autism spectrum disorder many of times are lacking what we call a theory of mind. Now, a theory of mind is a developmental concept that kids begin to understand that other people have different mental states, and those mental states influence their behaviors. So if I'm asking my mother for a cookie, another child understands that I must be hungry and that's why I want a cookie. But many kids with autism don't have that kind of mind reading ability. It's not really mind reading, but it's that understanding that other people are thinking different things. There was a classic experiment done with this piggy bank. It was really cute. They would bring kids in, and they would show kids that there were coins inside a piggy bank, and obviously these look like European coins inside a piggy bank. And then in front of the kids' eyes, they would replace the coins with marbles and have the kids shake it and would say, "Now what's in there?" And the kids would say, "Marbles." And then they would say to the child, "Okay, let's say your friend came in and they didn't know what we did here, and you gave them the piggy bank. What would they say is in the piggy bank?" And the child would often say, "Marbles." Younger kids say marbles. That shows they have not acquired a theory of mind because they don't understand that their friend doesn't know what they know. But the older kids would say coins, because you would naturally think there are coins in a piggy bank, and kids did not have the knowledge that that had been replaced. So kind of being able to read other people's minds and understand that people have different states is theory of mind. And many kids on the spectrum are lacking that. Okay, so what about treatment? I've already mentioned that the earlier that this is identified in kids, the better. There are many cognitive behavioral therapies that can be done that can help teach kids speech and proper social skills, things like eye contact through reinforcement. And the earlier this is started, the more successful this tends to be. There's new lines of treatment that use tablets to enhance communication, especially for kids who really have problems communicating their feeling. There are medications. There aren't medications that cure autism or reduce the incidence, but they can treat the feelings and the problems that are sometimes associated with it. For example, anxiety, depression, the aggression, especially antipsychotic medications or seizure medications have been learned or have been used to try and treat the aggression that goes along with it. And then the stereotypy. Stereotypy is the repetitive movements, the hand waving or the head banging or the kicking. Those medications have been helpful. I also want to add that interventions work best, and really they will only work when parents participate. Kids with autism spectrum disorder typically need really structured environments. They need routine. That's really important for them. And then parents need to identify reinforcers for the kid, because the things that reinforce typically developing kids, like praise or smiles or hugs, don't always work for kids who have autism spectrum disorder. So it's important to learn what will help them. But the bottom line is, the earlier the treatment, the better. Okay, one other neurodevelopmental disorder that I want to spend some attention here is, of course, the most frequently diagnosed disorder in kids, and that is ADHD, attention deficit hyperactivity disorder. So this involves a number of characteristics. The three main ones is that it's a condition that involves inattention, hyperactivity, and impulsivity. And I'll talk in just a minute about each of those separately. It is usually not diagnosed until the early school years, until a child enters school, because that's when they're expected to start sitting and attending for a period of time, and really highlights the difficulties that kids have controlling activity and paying attention. If kids go to a structured preschool before kindergarten, which most kids do, but not everyone does, it may be diagnosed earlier. So the average age of diagnosis right now is around 7, but the symptoms usually begin to appear around ages 3 to 6, because that's when more preschool focused kind of work happens. But most of the time, parents who have a child diagnosed with ADHD can in fact report that they have been very active really from a very early time. Okay, so let's go through some of the symptoms here. We'll start off with inattention. You do not need to know all of these. I just want to present you with some examples and just give you the wide range of things that can happen here. So as far as the inattention, these are kids who have trouble following directions, have trouble listening. They may move from one uncompleted task to another. They have difficulty finishing tasks. They lose things that are often necessary for tasks, and they get bored very easily. So you can read some of those other ones there yourself, but those are the main ones I wanted to highlight. Those symptoms of inattention need to be present in at least 2 environments. That should be greater than or at least 2 environments. So if a kid is only behaving this way at home but is fine in school, that's probably not ADHD. The next category of symptoms are the symptoms of hyperactivity and impulsivity. So again, I don't expect you to memorize all these, but here are just a couple of things. Fidgetiness, inability to sit still, kids who run or climb in inappropriate situations, talking excessively. This is one of the biggest issues that teachers often have. It's hard for kids to stop talking. Blurting out answers to questions without raising their hand. Kids have difficulty taking turns, and they will also interrupt others' conversations or games many times. And there are others listed here, but those are just a few examples that we know. Here's another chart with some statistics. This is an interesting one, looking at the rates of ADHD diagnosis here in the country. And I think what you can see is here out in the West, they have the lowest rates, and the darkest rates we've got really some of the southern countries, West Virginia, Kentucky, Louisville, I think that's Alabama, right down there. And then Ohio is kind of in the middle, the 8.1. So also out west, they're a little bit lower. So kind of some interesting trends that are sometimes a bit hard to understand. Scientists and researchers are still trying to understand that a little bit better. It is certainly one of the most common reasons that kids are referred to mental health services in the United States. And it's been shown, do I have the statistic? It's the next page. I need to advance here. See, I still talk to myself even when I'm recording. Let me get to that. Talk about some of the consequences that we know about of ADHD. The main things are academic skill and social skill problems. So kids really may struggle in school because they are unable to pay attention long enough or to deal with the typical structure of school, which is sitting still, paying attention. That's not conducive for these kids. And then social skill deficiency, which happens. These kids really can have problems with friendships, self-esteem issues, because they know at some level that they are different and struggle with their social friendships. This affects anywhere from 3 to 5% of school-age kids diagnosed, and again, this is more heavily diagnosed in boys. Between 70 to 80% diagnosed are boys. Another issue that these often co-occur with other disorders. So a child may be diagnosed with ADHD, but there may be other things going on as well. So 5 out of 10 have behavioral conduct issues. So this is a range. This can be anywhere from delinquency and truancy to just less severe problems. And then 3 out of 10 have anxiety because they get messages that their behavior is inappropriate, but they truly don't have control over it. One of the problems we have here is that there is no single test to diagnose this disorder. What clinicians do is get input from parents if they can. They get input from teachers. There are checklists they use, which I'll show you on the next slide. But there isn't a blood test, there isn't a biological test that can be used. And most of the time, this disorder is diagnosed by pediatricians because, as I mentioned to you before, there are not enough child clinicians, not enough child psychologists, not enough child psychiatrists to go around. And so most of the time what happens, and this is one of the reasons it may be overdiagnosed, is that a parent takes a child into the pediatrician, the teacher says he can't sit still, says he's blurting out in class. The pediatrician, because they don't have an hour to do a proper diagnosis, and that's not their training anyway, will say, yeah, it sounds like ADD, let's try some medicine and see if it works. And if it works, which it's probably going to kind of calm even typical kids, then the assumption is made that yes, okay, the child had ADHD, and that may be true or it may not be true. So we have a real problem with diagnosis because we do not have enough child clinicians. Whoops. So there are 2 checklists here. One of the most common ones for diagnosis are the Connors Parent and Teacher Questionnaire. In a best situation, this questionnaire is given to the teachers. And so the teacher rates, okay, is the child restless? Are they squirmy? Are they sassy? Are they overly sensitive? Do they daydream? Do they appear to lack leadership? And so they sum up the score, and that gives us an indication from the parents' or teacher's point of view. And then over here, similar kinds of things, except something you would see at a home setting. Are they excitable? Are they impulsive? Are they restless, always up on the go? Are they destructive? Same kind of thing. So for the best diagnosis possible, you want to have parents and teachers fill this out. Another example of how our diagnosis is working and is leading to the uptick in the number of kids diagnosed. So back in the late 90s, we had around 6% prevalence, and now it's up around 10%. But again, this is probably an overdiagnosis. The statistic I gave you a little bit ago probably is a bit more accurate. So we've got a range, mostly because of issues with diagnoses. Now, one of the things that people are often interested in is what are the long-term outcomes for ADHD? So do kids outgrow this? And the answer is, in some instances, yes, their behavior changes. We know that about 75% of kids diagnosed with this will still have some difficulties in adolescence, and then up to 60% of adults diagnosed as kids will have some symptoms, mostly problems with inattention and concentration. But only about 10% will reach their mid-20s with full diagnostic categories still being met. That's much more unusual. But we know that those people who do get to adulthood have a greater risk for substance abuse. That's been shown through study after study. And then the best predictor of problems in adulthood is aggression. So kids who really have difficulties with aggression as their kids, those tend to have the most problems as adults. But knowing that, it gives us good room for intervention. Okay, what's the cause of ADHD? Well, they're not real clear. What we have are theories or possibilities. So we do know that genetics and biology, of course, are going to play a role. So when we look at kids who have ADHD, we do find that there's an increased likelihood that parents and siblings have ADHD, whether it's diagnosed or not. We find that many times parents of kids with ADHD are impulsive and aggressive themselves. We know that there seems to be some abnormal dopamine functioning of kids with ADHD. And a study that just came out last year found that there's a tie to maternal smoking and kids with ADHD. Kids whose mothers smoke around them, like in this picture, are twice as likely to be diagnosed with ADHD. So that's an important finding. What about family and psychological causes here? What we know is that there are correlates. There are things that are related. We don't have cause-effect statements. We know that kids with ADHD often come from families where parents are short-tempered, stressed, and overly busy. They're more likely to come from homes in the city and with a lower socioeconomic status. And we also know that they're more likely to have kind of a conflictual relationship with their parents. So there's a lot more fighting and turmoil in the home. Okay, treatment. Now, we do have a group that's going to be doing their PSA on this, and I have to post those. That's my goal, but I just want to give you a little bit of information about treatment. The main treatment for ADHD is drugs, but I want to show you, draw your attention to this little model up here. This is the best possible treatment for kids with ADHD. Counseling for the parent and the child, the parent to help learn how to intervene with the child. Interventions done at school, which of course intervention specialists are trained to do, but we don't have enough of them, and then medications. So the medications that are typically used are central nervous system stimulants, things like Ritalin, Adderall. We're all pretty familiar with those. Those work to reduce hyperactivity and increase concentration. Oftentimes kids will only take them during school days. They may take a break from them in the summers or perhaps the weekends if the parents are able to do that. But it does have a significant effect and really can help kids do better in school. All these medications have short-term effects. They take about 30 minutes to work and they wear off in 4 to 6 hours. So oftentimes kids will take medicine when they get up in the morning and then may take it again at lunch. And these medications really are effective on kids who have aggression as a difficulty. So it can significantly reduce the level of aggression they display. One of the things the meds do, because people say, well, why in the world would we give a kid with ADHD a stimulant? It's because of the action of the stimulant medication. They seem to stimulate dopamine activity in the frontal lobe. So that frontal lobe, of course, is in charge of planning and decision making, and it seems to help that take over and be in charge a bit more than kids who aren't on the medication. Other medications that are sometimes used for kids, antidepressants to treat the depression that may go along with this, and then antipsychotics have been useful for kids, especially with aggression. The biggest problems that we have with medication, as I've mentioned, this disorder may be overdiagnosed, and so we've got a lot of kids that perhaps are over-medicated as a result of this. And for some kids, it causes problems with sleeping, especially insomnia. Many kids have appetite disturbance. They're just never hungry. They just don't want to eat. And then it causes some kids to have headaches. Behavioral treatment. Now, I just want to mention, for a lot of people, this is what they do. This is all they do. They will just do medication. And for some kids, that's perfectly sufficient. But for other kids, they need more interventions, and we hope that parents will be able to follow through on that, but that doesn't always happen. So behavioral treatments include things like positive reinforcement, mostly positive reinforcement, never punishment, to change social behaviors that kids have. So we're rewarding kids for behaviors that are good. So if they are handling a situation in a good way, or receive a disappointment but handle it well, they may get some kind of a reward for that. So that seems to be the best way to handle behavioral treatment. And it gets really complex. So parents of kids with ADHD, they have a whole system worked out. And then school interventions, which are best administered by a specialist, an early intervention specialist, but as I said, there's not enough of them, so that doesn't always happen. But generally, teachers are trained to, again, use positive reinforcement, Praise the appropriate behavior kids are displaying and ignore the other inappropriate behavior if they can. Now, if a child is bothering other kids or is being aggressive, then they have to do other things. Setting explicit rules and structure are important. And then back to positive reinforcement, rewarding daily goals. So teachers who are specialized in this have whole programs and just undergo years of training to learn how to best help kids with these issues. So those are the two disorders that I wanted to talk about, the two most commonly diagnosed in this chapter. And make sure that you go ahead and read about conduct disorder and oppositional defiant disorder.